and because of it, very often surgical method of treatment we use when we treat a patient with atrial fibrillation, especially with paroxysmal form of atrial fibrillation. Atrial fibrillation can be treated by continuous conduction of several independent wavelets propagating through the atrial musculature in similarly chaotic manner. The diagnosis of atrial fibrillation requires written documentation using an electrocardiogram showing the typical pattern of atrial fibrillation. Absolutely irregular intervals and no distinct P waves. P wave absent in patient with atrial fibrillation. By accepted convention, an episode lasting at least 30 seconds is diagnostic. Because sometimes episode may be less than 30 seconds, especially in Holter monitor, and it's very difficult to differentiate between atrial fibrillation and atrial tachycardia, for example. On this ECG, we can see atrial fibrillation. What we see in this ECG? At first, no P wave. P wave absent. No P wave before or after case, P wave absent. And we see small F waves. But at first, of course, we see irregular rhythm without P wave, the main sign of atrial fibrillation. No P wave and irregular rhythm, 95% it's atrial fibrillation, students. Individuals with atrial fibrillation may be symptomatic or asymptomatic. Asymptomatic, or we call silent atrial fibrillation. Many atrial fibrillation patients have both symptomatic and asymptomatic episodes of atrial fibrillation. And students are more dangerous if your patient with atrial fibrillation are symptomatic, because high risk of stroke present in this patient, but patient doesn't feel his arrhythmia. And this is a big problem if your patient is symptomatic. When you treat this patient and your patient with atrial fibrillation are symptomatic, it's normal. There is a good evidence that prolonged ECG monitoring which the detection of undiagnosed atrial fibrillation and monitoring, for example, for 72 hours after a stroke or even longer periods. If your patient with stroke, especially with ischemic stroke, very often the main cause of this ischemic stroke are atrial fibrillation. It's maybe asymptomatic atrial fibrillation. And for this patient, of course, Holter ECG, especially more than 24 hours, it's very useful to diagnose the main cause. And this, we can see paroxysm of atrial fibrillation. Why I call it paroxysm? Because at first, we see normal sinus rhythm. Now I show you P wave, normal P wave before QRS complex. P wave at first present. This P wave, this P wave, this. But this episode without P waves. And now we see abnormal rhythm, irregular rhythm without P wave. This paroxysm of atrial fibrillation. It may be very short paroxysm, but short or prolonged paroxysm both increase risk of sudden death and risk of stroke. Once the ECG diagnosis of atrial fibrillation has been established, the ECG monitoring can inform management in the context of a change in symptoms or new symptoms, suspected progression of atrial fibrillation, monitoring of drug effect or ventricular rate, and monitoring of antiarrhythmic drug effects or catheter ablation for rhythm control. Today we're going to discuss not only atrial fibrillation and also atrial flutter because treatment practically the same for this patient. Only on ECG we see a little difference. And right atrial isthmus-dependent flutter has a typical ECG pattern and ventricular rate. The prevalence of atrial flutter is less than 1/10 of the prevalence of atrial fibrillation. Atrial flutter often coexist with or precedes atrial fibrillation, and vagal stimulation or intravenous adenosine can therefore be helpful to unmask atrial flutter. The management of atrial flutter we'll discuss later. And now I want to show you ECG with atrial flutter, and you can compare with atrial fibrillation. In atrial fibrillation, we see very small F waves and irregular rhythm. Very often atrial flutter, regular flutter. Regular, I mean, are intervals equal or practically equal. And we see big F waves, big, and very often we call it sawtooth morphology. Because it looks like sawtooth. And very often we see big F waves in inferior leads. What is mean inferior leads? Second standard, third, and AVF leads. It's an inferior wall of left ventricle. Flutter may be typical or atypical flutter. And if flutter typical, negative flutter waves we see in second, third, and AVF leads, we call it anti-clockwise flutter. Atypical flutter also may be present, and we see positive F waves in second, third, and AVF leads. We call it clockwise flutter. Atypical flutter more difficult to diagnosis. Classification of atrial fibrillation and flutter the same. First, diagnosed atrial fibrillation. It means atrial fibrillation that has not been diagnosed before, irrespective of the duration of the arrhythmia or the presence and severity of atrial fibrillation-related symptoms. Second, paroxysmal atrial fibrillation. It means self-terminating, in most cases within 48 hours. Some atrial fibrillation paroxysm may continue for up to 7 days. Atrial fibrillation episodes that are cardioverted with 7 days should be considered paroxysmal. Persistent atrial fibrillation. Atrial fibrillation that lasts longer than 7 days, including episodes that are terminated by cardioversion, either with drugs or by direct current cardioversion, after 7 days or more. Next, long-standing persistent atrial fibrillation. This atrial fibrillation persisted in patient more than 1 year, and our choice, together with patient, rhythm control strategy. Next, permanent atrial fibrillation. Atrial fibrillation that is accepted by the patient and physician, and for this patient, our therapy, rate control therapy. Clinical types of atrial fibrillation also important because these help us to think about strategy, to think about management, treatment for our patient. First class, very often we see atrial fibrillation secondary to structural heart disease. This atrial fibrillation we see in patients with left ventricle systolic or diastolic dysfunction, long-standing hypertension with left ventricle hypertrophy, or other structural heart disease. And the onset of atrial fibrillation in this group of patients is a common cause of hospitalization and predictor of poor outcome. Possible mechanism of this atrial fibrillation: increased arterial pressure and atrial structure remodeling together with activation of the sympathetic and renin-angiotensin system. Next, focal atrial fibrillation. This group of patients with repetitive atrial runs and frequent short episodes of paroxysmal atrial fibrillation. Often, this patient highly symptomatic, younger patient with distinguishable atrial waves, atrial ectopy, and atrial tachycardia, treating in atrial fibrillation. Localized triggers in most cases originating from the pulmonary veins, and this initiate atrial fibrillation. For this patient, a very useful therapy, surgical method of treatment, cardio ablation of pulmonary veins. Next type, polygenic atrial fibrillation. Atrial fibrillation inquiries of common gene variants that have been associated with early onset atrial fibrillation. Currently under study, the presence of selected gene variants may also influence treatment outcomes. Next, postoperative atrial fibrillation. New onset of atrial fibrillation, usually self-terminating very short paroxysm, after major, typical cardiac surgery in patients who were in sinus rhythm before surgery and had no prehistory of atrial fibrillation. And a mechanism for this inflammation, atrial oxidative stress, high sympathetic tone, electrolyte changes, and volume overloading high, possibly interacting with a pre-existing substrate. Next group, next clinical type, atrial fibrillation in patients with mitral stenosis or prosthetic heart valves. Atrial fibrillation in patients with mitral stenosis after mitral valve surgery, and in some cases other valvular diseases. Left atrial pressure is stenosis, and volume regurgitation load are the main drivers of atrial enlargement and structure atrial remodeling in this patient. Next clinical type, atrial fibrillation in athletes. Usually paroxysmal form we see in athletes related to duration and intensity of the training. And possible pathophysiological mechanism, increased vagal tone and atrial volume. And in athletes, very often we see atrial fibrillation at night. Next, monogenetic atrial fibrillation. This type we see in patients with cardiomyopathies, including channelopathies, and very high risk in this patient of sudden death. Symptoms in atrial fibrillation. We said patient may be asymptomatic, but also maybe symptoms like palpitation, lateral gap, dyspnea, chest tightness, sleeping difficulties, and psychosocial distress maybe. And because very different symptoms may be in our patient with atrial fibrillation, we need to use a special scale to describe our symptoms, in our patient. And now you can see here symptom scale. First, score. Patient without symptoms. Atrial fibrillation does not cause any symptom. It may be true asymptomatic atrial fibrillation, or maybe atrial fibrillation when we treat our patient. And if we treat our patient and our strategy rate control therapy on this patient, if score 1, of course, it's a good treatment. Second A, mild symptoms. What does mean mild symptoms in our patient? Normal daily activity not affected by symptoms related to atrial fibrillation. Second, be moderate symptoms. Normal daily activity not affected by symptoms related to atrial fibrillation, but patient troubled by symptoms. Patient feel symptoms, patient maybe feel palpitation sometimes, and patient troubled about it. Next, severe. Severe, it means normal daily activity affected by symptoms related to atrial fibrillation. Problem in normal daily activity in this patient. And next, disabling symptoms. Normal daily activity discontinued. Very severe symptom in this patient. Essential investigation for atrial fibrillation. At first, complete medical history should be taken, and all patients should undergo clinical evaluations that include thorough assessment for concomitant condition establishing the atrial fibrillation, estimation of stroke risk, and atrial fibrillation related symptoms such as thromboembolism and left ventricle dysfunction. Next, of course, 12 leads ECG, and not only for diagnosis atrial fibrillation, of course for diagnosis atrial fibrillation, but also for diagnosis additional diseases in our patient, maybe this post-MI patient, maybe patient with left ventricle hypertrophy, and this help us to diagnose structure heart disease. National blood test, of course, thyroid hormone, because very often high or low level of thyroid hormone may cause atrial fibrillation, especially in young patients. Kidney function, creatinine, glomerular filtration rate, we need to check because it's important when we start our treatment of patient, and if we use anticoagulants, especially new oral anticoagulants. If patient with low glomerular filtration rate, we need decrease dosage of anticoagulants. Electrolytes, we should check potassium, sodium, magnesium, and full blood count, of course. Next, transthoracic echocardiography. This recommended for all patients with atrial fibrillation, because at first we can identify structure, heart disease, valvular problem, or we measure left ventricle, left atrial sides, and for prognosis it's very important when we decide what the type of therapy need for my patient, rhythm control or rate control therapy. Sometimes we use some additional investigation, additional test for this patient. Ambulatory ECG monitoring. For example, your patient with a very short paroxysm of atrial fibrillation, and on standard ECG we can't see this paroxysm. But it's very important to see on ECG, and we recommend for this patient Holter ECG. Next, transesophageal echocardiography. For some patients, we recommend this method. Coronary angiography or stress testing if we think ischemia is the main cause of this atrial fibrillation. For some patients, computed tomography or magnetic resonance imaging of the brain, especially in patients with ischemic stroke. Most atrial fibrillation patients need regular follow-up to ensure continued optimal management. Follow-up may undertaken in primary care by specially trained nurses, by cardiologists, or by atrial fibrillation specialists. Specialists should coordinate care and follow-up. Atrial fibrillation management comprises therapies with prognostic impact. It's called anticoagulation therapy and treatment of cardiovascular conditions, and therapies predominantly providing symptomatic benefit, rate control and rhythm control. Very important, of course, stroke prevention therapy in atrial fibrillation patients, because we said very high risk of ischemic stroke in patients with atrial fibrillation, and oral anticoagulant can prevent the majority of ischemic strokes in atrial fibrillation, and this, very important, students, can prolong life of this patient. Of course, this is important. Not antiplatelet therapy, not aspirin, only oral anticoagulant therapy need patient with atrial fibrillation. And first, recommended estimating stroke risk in atrial fibrillation patients based on the CHATS-TOWASC score. In general, patients without clinical stroke risk factors do not need antithrombotic therapy, while patients with stroke risk factors, men in CHATS-TOWASC score if 1 point and more, and women 2 and more, these patients need anticoagulant therapy. In CHATS-TOWASC score, this you can see on slide. Heart failure, if in your patient, 1 point. Hypertension, 1 point. Age more than 75 years, 2 points. Diabetes mellitus, 1 point. Previous stroke, 2. If vascular diseases like myocardial infarction or aortic plaque, 1 point. And age 65, 74 years, 1 point. And female gender, also 1 point. And if your patient, for example, men with arterial hypertension and with diabetes, 2 points. Of course, this patient need anticoagulants. If your patient, age less than 65, for example, it's men, and no additional diseases like this patient needed anticoagulant therapy. But very rare with a patient who needed anticoagulant therapy with atrial fibrillation. And at first, when we treat patient with atrial fibrillation, we need to estimate stroke risk and CHATS-TOWASC score. If 0, no anticoagulants, no antiplatelet therapy. 1, consider oral anticoagulants. Equal or more than 2, oral anticoagulants recommend for all genders. Stroke prevention maybe with warfarin, this vitamin K antagonist. And when we treat with warfarin, we need control INR, international lowest ratio. And if we prescribe warfarin, INR should be between 2 and 3. If INR more than 3, it's increased risk of bleeding. If less than 2, it's increased risk of stroke, of thrombus. And for risk of bleeding, we need next scale, this heart-blood score. We need to calculate in our patient. If hypertension, 1 point, abnormal renal or liver function, 1 or 2 points, stroke, 1 point, bleeding, previous bleeding, 1 point, labile INR, 1 point, in elderly patients also 1 point, and drugs or alcohol using 1 or 2 points. And if your patient with 3 and more points, very high risk of bleeding. But we need to know modifiable bleeding risk factors. What we can change in our patient to decrease risk of bleeding. Hypertension, of course, we can change because we prescribe for this patient special antihypertensive drugs. Labile INR, this all can change if we change medication in our patient. For example, we change warfarin and prescribe rivaroxaban for patient. Medication predisposing to bleeding, for example, antiplatelet drugs or non-steroid anti-inflammatory drugs, also increase bleeding. And if your patient stop taking these drugs, of course, will decrease risk of bleeding. Excess of alcohol is also modifiable bleeding risk factor. Potentially modifiable bleeding risk factor we also can change. Anemia, for example, renal function, sometimes liver function, also sometimes, and we know some non-modifiable bleeding risk factors. Age, of course, we can't change it. History of major bleeding, yes, we can't change. Previous stroke, dialysis-dependent kidney disease or renal transplant, cirrhotic liver disease, malignancy, genetic factors. And today, very often we use non-vitamin K antagonist oral anticoagulants, new oral anticoagulants. These drugs do not require INR monitoring. And we know some drugs like the dabigatran. We can use this drug 150 milligrams twice daily, apixaban 5 mg twice daily, edexaban 16 mg once daily, and rivaroxaban 20 mg once daily. We should monitor when we treat with these drugs kidney function, and if kidney function abnormal, estimated glomerular filtration rate less than 30, some drugs we can't use, for example, rivaroxaban, dabigatran, only apixaban we can use, but we need to decrease dosage of this medication. Antiplatelet therapy, students, cannot be recommended for stroke prevention in atrial fibrillation therapy. It means if your patient with atrial fibrillation and you prescribe only aspirin for this patient, you increase the risk of stroke in this patient. And combination of oral anticoagulants and antiplatelet therapy also increase bleeding risk. And if, for example, your patient with ischemic heart disease after MI, of course, you know, this patient needs aspirin. But now this patient with atrial fibrillation, and you're in doubt what my patient need, warfarin, for example, or aspirin. Of course, your patient needs warfarin because atrial fibrillation, in a patient with atrial fibrillation, we recommend anticoagulant therapy, not antiplatelet therapy. Next, prevention stroke therapy in some patients who can't be treated with anticoagulants. We can use this type of therapy, left atrial appendage occlusion and exclusion. Now heart, there is one structure, left atrial appendage, and in patient with atrial fibrillation, very often at this place originate thrombus. And we can see this thrombus on standard echo. And if your patient with contraindication for anticoagulant therapy, you can recommend left atrial appendage occlusion. Sometimes bleeding, of course, may be if your patient take anticoagulants. And this side effect. And if your patient with mild bleeding, if patient take warfarin, delay warfarin until INR less 2. If new oral anticoagulant like rivaroxaban or apixaban, delay these drugs for 1 day. Maybe moderate to severe bleeding. Fluid replacement, blood transfusion, treat bleeding cause we need. And if patient take warfarin, we know about antagonist of warfarin, vitamin K, 1 to 10 mg intravenosus we recommend. And if your patient with severe or life-threatening bleeding, if patient took warfarin, consider prothrombin complex concentrate in fresh frozen plasma, healthier patient. If your patient take, for example, dabigatran, for dabigatran we know about antidote, idurcizumab, it's antidote for dabigatran, or prothrombin complex we can use if anticoagulant without antidote, for example, apixaban. We don't know about antidote for apixaban. Next, therapy. We know two types of therapy for patients with atrial fibrillation: rate control therapy and rhythm control therapy. At first, we're going to discuss rate control therapy. Rate control is an integral part of the management of atrial fibrillation patients and often sufficient to improve atrial fibrillation-related symptoms. Pharmacological rate control can be achieved for acute or long-term rate control with beta blockers, digoxin, calcium channel blockers like diltiazem and verapamil, or sometimes maybe combination therapy. A number of antiarrhythmic drugs also have rate limiting properties, but they should only be used in patients needing rhythm control therapy, not rate control therapy. Very rare for rate control therapy, we use antiarrhythmic drugs like amiodarone or propafenone, because aim in rate control therapy decrease heart rate, but atrial fibrillation still present in patient. Or acute rate control. Acute rate control need patient with practically all types of atrial fibrillation with paroxysmal, permanent, or persistent form of atrial fibrillation. And for acute heart rate control, we can use beta blockers or calcium channel blockers and digoxin, of course. If your patient with left ejection fraction more than 40%, you can use all these drugs, beta blockers, diltiazem, verapamil, and digoxin, but we need to avoid bradycardia. But if your patient with left ejection fraction less than 40%, only small dosage of beta blockers you can use and digoxin. No calcium channel blockers for this patient. It's contraindicated. For some patients, of course, maybe a long-term pharmacological rate control, practically for all life. And beta blockers is the first line of therapy for this patient. But calcium channel blockers also we can use, especially if your patient with asthma or COPD. And digoxin also we can add to beta blockers or calcium channel blockers. And those we are going to discuss at our practical classes. What's the charges of heart rate when we treat patient with rate control therapy? Heart rate in this patient should be in the range 80 BPM to 110. We said we need avoid bradycardia in patient with atrial fibrillation. Sometimes for some patients with atrial fibrillation, we can use atrioventricular node ablation and pacing. If we can't control ventricular rate with drugs and with beta blockers or calcium channel blockers, we can use this method of therapy. But after atrioventricular node ablation, patient need pacing. Next type of therapy, rhythm control therapy. Rhythm control therapy, it means we restore sinus rhythm, we maintain sinus rhythm in patients with atrial fibrillation. It may be acute restoration of sinus rhythm, it may be pharmacological cardioversion or electrical cardioversion. If your patient stable, it's your choice and patient choice, pharmacological or electrical cardioversion. If your patient unstable, only electrical cardioversion may be in this patient. And some antiarrhythmic drugs we use for pharmacological cardioversion, amiodarone, flecainide, ibutylite, propofenone, etc. We know next therapy pill in the pocket cardioversion. In some group of patients, in selected group of patients with infrequent symptomatic episodes of paroxysmal atrial fibrillation, we can use this type of therapy with flecainide or propofenone. But you need to know this patient stable and no structure heart disease. If your patient, for example, after MI, you can't recommend for this patient pill in the pocket therapy, only for patient without structure heart disease. And electrical cardioversion. Electrical cardioversion, I said we recommend for patient, for unstable patient, to restore sinus rhythm. For some patients, before electrical cardioversion, maybe treatment with amiodarone, flecainide. Of course, anticoagulation therapy as soon as possible we recommend for patients. Before electrical cardioversion we recommend. And after cardioversion, anticoagulants patient need to take minimum 3 weeks after cardioversion. For some patients, we recommend transesophageal echocardiography, especially if atrial fibrillation persists more than 48 hours, more than 2 days. If persists atrial fibrillation, this increase risk of stroke, risk of thrombus. And for this patient, to diagnose thrombus in left atrial appendage, only transesophageal echo may help the diagnosis. And rhythm control management, I repeat a little. If patient unstable, only electrical cardioversion. If patient stable and patient choice, pharmacological cardioversion, then will be your choice. Because pharmacological cardioversion depends of diseases that present in your patient. For example, if your patient with severe heart failure, you can use only amiodarone for this patient. If a patient without structural heart disease for pharmacological cardioversion, we can use all drugs, all antiarrhythmic drugs, for example, propofenone, flecainide. You can use all pill in the pocket therapy. Also, you can use. After cardioversion, of course, next problem, long-term antiarrhythmic drug therapy to prevent new paroxysm of atrial fibrillation. And it may be long-term treatment with amiodarone or maybe with beta blockers. You can choose any drugs, but structural heart disease, if present, very important because beta blockers not so effective like amiodarone to prevent new paroxysm, for example. Selection of antiarrhythmic drugs for long-term therapy. Safety first. You need to think about safety of these drugs, safety for this patient before you start treatment. In our previous lecture, we discussed antiarrhythmic drugs in general, and we said, for example, amiodarone, of course, very effective drugs. But also we said a lot of side effects, thyroid dysfunction, QT interval prolongation. And of course, it's not first-line therapy for patients with atrial fibrillation. We start, for example, with beta blockers, with calcium channel blockers in this patient. And if this effective, of course, patient needed more severe drugs like amiodarone. I said you at the beginning of my lecture about catheter ablation. Very often today we recommend catheter ablation for patients with atrial fibrillation, especially for young patients, especially for patients with very often paroxysm of atrial fibrillation. Especially for patients without severe structural heart disease, without severe heart failure, we recommend because catheter ablation, especially in patients with atrial flutter, will be very, very effective. And sometimes patients after catheter ablation needn't take antiarrhythmic drugs. And what's the treatment? Complete pulmonary vein isolation we use for patients with atrial fibrillation. Sometimes patients need not only one operation, sometimes patients need 2 or 3 times catheter ablation of pulmonary vein. And this may help your patient prevent new paroxysm of atrial fibrillation. Sometimes we use deep rhythm control therapy. Not sometimes. I think often we use this type of therapy combining antiarrhythmic drug and catheter ablation. We recommend antiarrhythmic drugs for 8 to 12 weeks after ablation to reduce the early recurrences of atrial fibrillation after catheter ablation. Then we can stop our therapy with antiarrhythmic drugs. And maybe combining antiarrhythmic drugs and pacemakers. Especially this type of rhythm control therapy very effective in patients with sick sinus syndrome tachybrady in this patient, sinus bradycardia together with paroxysm of atrial fibrillation. And for treatment, this patient very effective will be we implantate pacemaker for this patient and recommend some drugs. Next question about sports and atrial fibrillation. Physical activity improves cardiovascular health, with translates into a lower risk of atrial fibrillation. Therefore, physical activity is a cornerstone of preventing atrial fibrillation. But intensive sports practice increase the risk of atrial fibrillation later in life, probably mediated by altered automatic tone, volume load during exercise, atrial hypertrophy, and dilatation. And of course, to prevent atrial fibrillation, we recommend physical activity. It's not professional sport because we said in athletes also maybe atrial fibrillation. And in professional sportsmen, very often we see atrial fibrillation. Flutter. What about atrial flutter management? Practically the same, students. Treatment patient with atrial flutter and treatment patient with atrial fibrillation. Rate control and rhythm control strategy. For rate control, the same medication, beta blockers, diltiazem or verapamil. For rhythm control, at first place, catheter ablation of pulmonary veins, because more effective catheter ablation in patient with atrial flutter than in patient with atrial fibrillation. But if we avoid catheter ablation, the same drugs we can use for rhythm control therapy, amiodarone, dofetilide, or sotalol, flecainide, or propofenone, if chronic heart failure absent in your patient. And let's summarize a little. Atrial fibrillation. We know two types of therapy. Rate control therapy. It means your patient still with atrial fibrillation. You only decrease ventricular rate. And if you decrease heart rate in patient, you also decrease symptoms. And patient doesn't feel palpitation because his heart rate practically normal. And for rate control therapy, you use beta blockers plus digoxin, calcium channel blockers, maybe plus digoxin, atrial ventricular node ablation, flut plus pacing, and of course anticoagulation therapy. Rhythm control therapy, it may be a pharmacological or electrical cardioversion, antiarrhythmic drugs, then catheter ablation, atrial defibrillator, or surgery method of treatment. And anticoagulation therapy, very important for this patient. If a risk in CHADS to VASC score more than 1 point for men and more than 2 points for women, we recommend for this patient anticoagulation therapy. Sometimes it's difficult to understand because rhythm control therapy, it means we restore a sinus rhythm and now our patient on sinus rhythm. But we recommend anticoagulation, this patient on sinus rhythm. But this very, very important, students, if high risk of thrombosis, because sometimes paroxysm may be very short. We said 30 seconds maybe, but 30-second paroxysm also increase risk of thrombosis, and this increase risk of ischemic stroke. And because of it, if your patient with risk factors of thrombus, we recommend anticoagulation therapy, even your patient on sinus rhythm, but with history of atrial fibrillation. This is very important. And I finished my first lecture, students. Any question? Students, do you hear me?
You are now unmuted.
Students, if no question, maybe we start second lecture because I think it's your last lecture for today. Okay? Okay, start
You are
my
now
next
muted.
lecture. Also about arrhythmias, this lecture. Bradycardia, bradyarrhythmia. Next problem. And let's start. What does mean bradycardia? It's easy. Heartbeat less than 60 beats per minute we call bradycardia. Of course, bradycardia may be in healthy patient. And of course, bradycardia may be problem, maybe cause for some symptoms, for syncope, for example, maybe. And the main clinical manifestations of bradycardia. And two general categories of bradycardia: sinus node dysfunction and atrioventricular block. What's the main symptoms? Syncope, dizziness, angina, dyspnea, heart failure. What's the main causes? Bradycardia may be primary. We don't know about cause. But we think if it's patient, it's elderly patient, I think ischemic heart disease is the main cause. But if you're patient without symptom, typical for ischemic heart disease, of course you can say about it. Drug, of course, 21% students drug cause for bradycardia. Ischemia or infarction, 14%. Pacemaker failure, 6%. Some intoxication, 6%. Or electrolyte disorders, 4%. We said about syncope. Let's say a little about syncope. What it means, syncope? A transient, sudden loss of consciousness, usually leading to fainting. Syncope can be caused by a wide spectrum of conditions, ranging from the benign faint to potentially fatal cardiac arrhythmias. The challenge is to identify those that require specialist management. The underlying mechanism is hypertension due to a failure of cardiac output or a loss of peripheral vascular resistance. This results in a reduced cerebral perfusion and lost consciousness, a 6 to 8 second interruption to cerebral blood flow may be all that is required for syncope to occur. Syncope can occur without warning, but in some there are prodromal syndromes such as nausea, sweating, loss of balance, or altered vision. Patients with true syncope do not remember hitting the ground. 1 in 4 of the population will have at least one episode of syncope. Diagnosing syncope. The history and examination are the most important steps in differentiating syncope from non-syncopal causes of loss of consciousness. Conditions that mimic syncope with a loss of consciousness include epilepsy, hypoglycemia, intoxication. Some conditions without loss of consciousness may mimic syncope, pulse, cataplexy, psychogenic syncope, transient ischemic attack. Many elderly patients with syncope describe the episodes as false, often failing to recognize loss of consciousness. And we need to know questions to ask. Inquire about the 3 P's. Provocative factors: fatigue, dehydration, warm atmospheres, emotional circumstances, fear, pain. Prodromes: nausea, sweating, dizziness, abdominal discomfort. Postural components also very important. Patient is standing, sitting, or lying position. Try to obtain a witness account of the episode. Ask about the appearances of the patient during the episode. Was the pale? Was the serious activity, and if so, for how long? Remember that short-lived series and myoclonic jerks often occur in simple vasovagal syncope. Next, how long did the episode last? Arrhythmic syncope can be very brief with almost immediate recovery, such an intermittent AV block, we call it stock Adams attacks. Vasovagal episodes tend to be a little longer. Also, these two can be quite short-lived. How long did the patient take to recover, and how did they feel? Was there confusion? Following vasovagal episodes, patients may report nausea, vomiting, and prolonged lightheadedness with recurrent syncope or pre-syncope if they stand too quickly. They may also feel profound tiredness, which can last for hours, and often patients report sleeping in the immediate aftermath of episodes. Cause of syncope. Not only bradycardia is students the main cause of syncope, and very often we see neuromediated reflex syncope, orthostatic hypotension cause for syncope. Cardiac causes represent only 15% of all causes of syncope. Some cardiovascular diseases also may be cause for syncope, for example, obstructive valvular disease, left ventricular outflow obstruction, hypertrophic cardiomyopathy, aortic dissection also may be cause for syncope, pericardial tamponade, pulmonary hypertension, pulmonary embolus, atrial myxoma. But if it's cardiac causes, it may be sinus node dysfunction, AV block, paroxysmal arrhythmias, some inherited syndromes like long QT interval syndrome or Brugada syndrome, drug-induced bradycardia or prolonged QT interval also may be cause for arrhythmic syncope. What investigation we recommend for patients with syncope? At first, well-lit ECG. And if it's syncope connected with cardiac problem, what can we see? For example, Q wave on ECG. We diagnosis previous MI. Maybe left bundle or right bundle branch block, or left anterior or posterior gamma block. AV block, second degree or higher, may be cause for syncope. Sinus bradycardia if heart rate less than 50 BPM, or sinus pulses more than 3 seconds also may be cause for syncope. Pre-excitation syndrome if short PI interval and delta wave present on ECG, or Parkinson-White syndrome we call it. Prolonged QT interval if white QS complex more than 0.12 seconds, we see also this may be in patient with structure heart disease. Right bundle branch block with ST segment elevation in V1 with 3, and we suspect Brugada syndrome. This channelopathy also may be caused for very dangerous arrhythmias, for example, ventricular tachycardia may be in this patient, and ventricular tachycardia, of course, may be caused with syncope. Chest X-ray, we also recommend for this patient to see cardiac enlargement or aortic dissection. Routine blood testing, plasma glucose, Also, patient need to check carotid sinus massage for some patient, and in selected patient echocardiography or 24 hours ECG we recommend. Who should be admitted? Most patients who present following a single episode of syncope can be investigated as an outpatient. In hospital monitoring and investigations warranted if the initial clinic evaluation suggests significant structure heart disease or when syncope is recurrent or disabling. Patients without clinical evidence of structure heart disease and no family history of sudden death who present with an isolated episode of classical vasovagal or situational syncope can be discharged back without the need for any specific follow-up. Carotid sinus massage, we said about it. Used to diagnose carotid sinus hypersensitivity because very often carotid sinus hypersensitivity cause for syncope. And perform this with continuous ECG recording and ideally bed-to-bed blood pressure monitoring since blood pressure changes are rapid. With the patient, spine pressure is applied to each carotid sinus in turn for 10 to 20 seconds. If no abnormal response is elected, the procedure can be repeated with the patient tilted upright. We need to avoid this method in patients with a history of recent stroke, if less than 3 months after stroke, carotid arthritis or non-carotid vascular disease. And carotid sinus hypersensitivity is defined as a ventricular pulse of more than 3 seconds or a drop of systolic pressure of more than 50 millimeters. And carotid sinus syndrome is a combination of syncope and carotid sinus hypersensitivity in patients in whom clinical evaluation and investigation has identified no other cause of syncope. Next method we use sometimes in patient syncope, especially if we suspect neurally mediated syncope. Tilt table testing we can use for this patient to diagnose vasovagal neurally mediated syncope. Neurally mediated vasovagal syncope, loss of consciousness in vasovagal syncope typically for less than 30 seconds, very short period. Also, patients relatives usually report longer. Likely, in the absence of cardiac disease and if there are provoking factors associated, furthermore, autonomic symptoms or syncope occur with head rotation, carotid sinus pressure. Situational syncope occurs when perfectly linked with swallowing, intuition, or coughing. Investigation for this, for diagnosis, carotid sinus massage, table testing. If tests are negative and symptoms recur, that consider prolonged ECG monitoring or implantable loop recording. And management for this carotid sinus syndrome usually responds well to dual chamber permanent pacing. For other neurally mediated syncope, treatment is less straightforward and patients should be referred for specialist advice. Non-pharmacological measures are the first-line treatments for the patient with vasovagal syndrome. These include education, assurance, tube training, leg crossing, or hand grips during prodromes. Pacing for vagal syncope can reduce symptoms in selected patients, but patient must be informed that it does not prevent the attacks. Next, cause for syncope, orthostatic hypotension. Commonly occurs shortly after standing up or after prolonged standing, typically in a hot, crowded room. Can occur after exertion. A systolic blood pressure drop of more than 20 millimeters after 3 minutes of standing, or a drop to less than 90 millimeters is defined as orthostatic hypotension, irrespective of whether symptoms occurs. The commonest cause is vasodilated drugs and diuretic therapy, especially in elderly. Don't forget about it if you see syncope in elderly patients, students. It's not very often connected with typical bradycardia with AV block, for example. Some drugs may be cause for orthostatic hypotension, like nitroglycerin or diuretic therapy with furosemide or hypothiazide, and cardiac syncope. Likely if syncope occurs in the presence of severe structure heart disease, particularly severe left ventricular impairment. Syncope in patients with poor cardiac function confers a bad prognosis. Symptoms can occur at any time and may be provoked by exertion, can occur while sitting or supine, can be associated with palpitation or chest discomfort. For this patient, we recommend echocardiography, prolonged ECG monitoring, and in selected patients, electrophysiological study. We said about medication that can be caused for bradycardia and for syncope. And the main group of these drugs, antihypertensive drugs, beta blockers. Of course, beta blockers may be caused for bradycardia sometimes, very severe bradycardia. Methyl dopa, non-dehydropyridine calcium channel blockers. Some antiarrhythmic drugs like amiodarone, sotalol, flecainide, procainamide also may be cause for bradycardia. Some psychoactive drugs, lithium, opioid analgesics, tricyclic antidepressants also may be cause for bradycardia and for syncope. Some drugs, cannabis, digoxin, ivabradine, muscle relaxants also may be cause for bradycardia. We know some conditions that are associated with bradycardia. It may be intrinsic, like cardiomyopathy, congenital heart disease, some diseases with infection or inflammation, for example, Chagas disease or myocarditis. Infiltrative disorders like amyloidosis, some rheumatological conditions like rheumatoid arthritis or scleroderma, systemic lupus erythematosus, and some extrinsic causes or conditions, carotid sinus hypersensitivity, we will discuss a little about it. Situational syncope may be in cough, defecation, bloating, stimulation, when patients sleep, especially if you're patient with sleep apnea. Some metabolic disorders, acidosis, hyperkalemia, hypothermia, hypothyroidism, hypoxia may be condition that associated with bradycardia. If you suspect bradycardia in your patient, what you recommend? Of course, a standard ECG. You recommend to diagnose rhythm, heart rate in your patient. Some exercise electrocardiographic testing to diagnose chronotropic incompetence, and ambulatory 24 or 48 hours electrocardiography we recommend. To ambulatory monitoring, rate monitoring, we use some device. It may be a standard holder, but maybe some loop recorders, maybe implantable cardiac monitor. For months, we can implantate this monitor to diagnose problem with rhythm. Next, what we use in patient with bradycardia for diagnosis. Imaging methods, transthoracic echocardiography, of course, polysomnography for diagnosis, sleep apnea, for example, implantable cardiac monitor, some laboratory tests, because we said sometimes electrolyte disorders may be cause for bradycardia, or hormone disorders also may be cause for bradycardia. If we see acute bradycardia, what's the treatment for this patient? It doesn't depend it's a signal dysfunction or AV block. If you see acute bradycardia, symptomatic bradycardia, what can you use? You can use atropine, 0.5 to 1 mg intravenous, and atropine may be repeated every 3 to 5 minutes to a maximum dose of 3 mg. Dopamine, 5 to 20 microgram per kilogram in minute intravenous we can use. Isoproterenol, 20 to 60 microgram intravenous. Aminophylline or theophylline in doses you can see in this slide. If you know cause for bradycardia and this, for example, calcium channel blocker overdose, you can use calcium chloride or calcium gluconate intravenous. If beta blocker or calcium channel blocker overdose, sometimes maybe together, we can use glucagon or high dose insulin therapy. And digoxin overdose, we can use digoxin antibody fragment, or all these drugs, of course. Very often we start with atropine in patient with acute bradycardia. In acute bradycardia, also we can use temporary pacing. Temporary pacing very often is a bridge to permanent pacing. And ideally, a temporary pacing while is only required if the patient cannot wait for a permanent system. We find recurrent or frequent systolic pulses causing syncope, any bradycardia with significant hemodynamic compromise, second degree morbid type 2 or third degree AV block, especially with wide, broad QRS complex and heart rate less than 40 BPM, and with severe hemodynamic consequences. In stable patient, we don't recommend temporary pacing. Bradycardia induced ventricular arrhythmia. Temporary pacing may be considered in recurrent symptomatic pulses more than 3 seconds, and prophylactic in acute MI patients with new B or 3 fascicular block or alternating right or left bundle branch block. And of course, it's a mistake if we use temporary pacing in patient with asymptomatic AV block or sinus node disease without significant symptoms. For prolonged therapy, we use permanent pacing, and permanent pacing may be dual chamber pacing or single chamber pacing, or very often Today we use dual chamber pacemaker. And in our practical classes, we will discuss with you pacemaker motor codes. Next question. Bradycardia attributable to sinus node dysfunction. Sinus node dysfunction, or very often we call it sick sinus syndrome, occurs as a result of disorders in automaticity, conduction, or both of the sino-atrial node, local cardiac pathology, systemic diseases that involve the heart, and medication or toxins can all be responsible for abnormal SA node function and may result in sick sinus syndrome. At first, it may be abnormal automaticity. We call it sinus arrest. Sinus arrest, it means problem with sinus node, and sinus node cannot originate normal impulses. And of course, it may be cause for severe bradycardia. Cause for sick sinus syndrome may be medication and toxins. We discussed these drugs when we discussed bradycardia in general. But I repeat a little: beta blockers, non-dehydropyridine calcium channel blockers, digoxin, may be cause for sick sinus syndrome. And first, your question for patient with bradycardia about medication, about drugs that your patient take every day. Infiltrative diseases like amyloidosis very often may be cause for sick sinus syndrome. Inflammatory diseases like rheumatic fever, pericarditis, diphtheria, Chagas disease, and other disorders. And SA nodal arterial disease, for example, atherosclerosis of SA nodal arterial disease, also may be cause for sick sinus syndrome. Some genetic mutation, of course, trauma, especially surgery trauma, maybe, and some other disorders, infection, hormone disorders, electrolyte disorders may be cause for sick sinus syndrome. Symptoms may be very different and range for these symptoms from mild fatigue to syncope. And the severity of clinical manifestation generally correlates with the heart rate or the pulse duration. Most patients with sick sinus syndrome present with one or more of the following non-specific symptoms, primarily due to bradycardia, sinus pulse, and sinus arrest. It may be fatigue, dizziness, or lightheadedness, a sensation of rapid fluttering heartbeats, palpitation. I said here at my first lecture of arrhythmia, palpitation is not very specific symptom for patients with arrhythmia, because a patient with tachyarrhythmia may be palpitation, and a patient with bradyarrhythmia also may be palpitation. Fainting or near fainting, dyspnea on exertion, chest pains or discomfort, slower than normal pulse, shortness of breath. Many of these signs and symptoms are caused by reduced blood flow to the brain when the heart beats too fast or too slow. And correlation between symptoms and bradycardia on ECG is considered to be the gold standard of diagnosis. This is very important, correlation, because a lot of symptoms not specific. Fatigue may be in healthy patient, But if patient with this complaint and on ECG you see at this moment bradycardia, of course, this may be sign of sick sinus syndrome. On ECG, in patient with sinus node dysfunction, we can see sinus bradycardia, ectopic atrial bradycardia, sinoatrial exit block, sinus pulse, sinus node arrest, tachybradycardia, tachybrady syndrome, and chronotropic incompetence. Sinus bradycardia. It's easy to diagnose on ECG because normal sinus rhythm and only heart rate less than 60 beats per minute. Especially important if heart rate less than 40 beats per minute because it may be real sick sinus syndrome. Ectopic atrial bradycardia, when we can see normal sinus rhythm, but we see atrial pacemaker and heart rate very often less than 50 bpm per minute. Sinoatrial exit block also may be in patient. Sometimes we can see drop beats. Sinus pulse, sinus node depolarized more than 3 seconds after the last atrial depolarization, or maybe sinus node arrest. Sinus node arrest, no evidence of sinus node depolarization, like on this ECG, this sinus node arrest. We see only line without P wave, without QRS complexes. Very dangerous tachybrady syndrome, sinus bradycardia or sinus pulse, alternating with periods of abnormal atrial tachycardia, atrial flut, or atrial fibrillation. And it's very difficult to treat patient with sick sinus syndrome tachybrady because we discussed with you, for example, your patient with atrial fibrillation. For this patient, we recommend beta blockers. But if sick sinus syndrome tachybrady, it means your patient sometimes with sinus bradycardia, sometimes with atrial fibrillation. And of course, you can't use beta blockers for this patient because sinus bradycardia is contraindication for patient with bradycardia. This also ECG with sick sinus syndrome tachybrady, and at first we see bradycardia, very prolonged interval, and then episode of atrial fibrillation. And how can we treat this patient? It's impossible to recommend for this patient beta blockers. I think other treatment this patient needs. I said here about chronotropic incompetence. Broadly, it's defined as an inability of the heart to increase its rate commensurate with increased activity or demand. In many studies translates to failure to attain 80% of expected heart rate reserved during exercise. Maximum heart rate multiplied 0.8. How can we calculate maximum heart rate? It's not only for sick patient and for healthy patient. You can calculate maximum heart rate for you. You can calculate your maximum heart rate. 220 minus age. If your age, for example, 20 years old, your maximum heart rate 200. If patient 35 years old, his maximum heart rate 185 bpm. And we need to calculate 80% of maximum heart rate. And if patient do exercises and can't achieve sub-maximum heart rate, 80% of maximum heart rate, we think about sinus node problem, sinus node dysfunction. Next, that help us to diagnose sick sinus syndrome, determining the intrinsic heart rate. May distinguish SA node dysfunction from slow heart rates resulting from high vagal tone. The normal intrinsic heart rate after administration of 0.2 mg per kilogram propranolol and 0.04 mg per kilogram atropine is 117.2 minus 0.53 multiplied by age in beats per minute. And low intrinsic heart rate is indicate of SA node disease. For example, your patient age of 40 years old. You calculate intrinsic heart rate for this patient, 96, for example. And if after propranolol and atropine, his heart rate less than 96, it's a sign of sinus node dysfunction. There are several ways to assess SA node function invasively. When we use electrophysiological testing, we calculate sinus node recovery time, defined as the longest pause after cessation of overdrive pacing of the right atrial near the SA node. Normal sinus node recovery time less than 1,500 milliseconds, and we calculate corrected for sinus cycle, means should be less than 550 milliseconds. And on electrophysiological testing, we also calculate atrial conduction time and normal atrial conduction time less than 125 milliseconds. If in your patient combination of abnormal intrinsic heart rate or abnormal atrial conduction time and low intrinsic heart rate, this very specific indicator of intrinsic SA node disease. Complication of SA node disease: sudden death, syncope, thromboembolic events including stroke, especially if it's tachybrady, sinus node dysfunction, heart failure, atrial tachyarrhythmias. What's the acute management of SA node? Of course, we can use atropine, isoproterenol, dopamine, dopamine, epinephrine, glucagon, or high-dose insulin therapy if beta blocker or calcium channel blocker overdose. If digoxin overdose, digoxin antibody fragments we can use, or temporary pacing if very severe bradycardia, and especially if symptomatic very severe bradycardia. Chronic therapy in patient with bradycardia connected with sinus node dysfunction, and in asymptomatic individuals with sinus bradycardia or sinus pulses that are secondary to physiological elevated parasympathetic tone, in patient with sleep-related sinus bradycardia or transient sinus pulses occurring during sleep, in patient with asymptomatic sinus node dysfunction, or those in whom the symptoms have been documented to occur in the absence of bradycardia or chronotropic incompetence, permanent pacing should not be performed. Patient presenting with symptomatic sinus node dysfunction secondary to a reversible cause should first be managed by directing this therapy at eliminating or mitigating the offending condition. In patient with symptomatic with symptoms that are directly attributable to SA node dysfunction in patients who develop symptomatic sinus bradycardia for which there are no alternative treatment and continued treatment is clinically necessary. Permanent pacing is indicated to increase heart rate and improve symptoms. For patients with tachybrady syndrome and symptoms attributable to bradycardia, permanent pacing is reasonable to increase heart rate and reduce symptoms. Recommendation for permanent pacing techniques and methods for chronic therapy in symptomatic patients with sinus node dysfunction, atrial pacing recommended or single chamber ventricular pacing. In symptomatic patient with SA node dysfunction and problem with atrial ventricular conduction, dual chamber pacing we recommend. And therapy of permanent pacing recommend for patient with SA node dysfunction and symptomatic bradycardia or sinus pulse with symptomatic chronotropic incompetence and symptomatic SA node dysfunction as a result of essential long-term drug therapy with no acceptable alternatives. Atrioventricular conduction disease also cause for bradycardia and for syncope connected with this bradycardia. A lot of causes for atrioventricular conduction disease, congenital, genetic, maybe infections, for example, Lyme carditis, toxoplasmosis may be cause for atrioventricular block, inflammatory diseases, myocarditis, amyloidosis, sarcoidosis, some cardiomyopathy, some systemic disorders, ischemic heart disease, acute MI, especially inferior acute MI, some metabolic disorders, neuromuscular diseases, some medication also may be caused. Atrioventricular block may be first degree, second degree. Second degree we divide in morbid type 1, morbid type 2, 2 is to 1, atrioventricular block, advanced maybe atrioventricular block, third degree atrioventricular block, we call it complete heart block, vagal mediated atrioventricular block, or infranodal block, also like atrioventricular block. Clinical presentation practically the same with sinus node dysfunction. Some patients may be asymptomatic, some patients maybe with not specific symptoms, dizziness, for example, fatigue also, but very dangerous syncope, of course. First degree atrioventricular block very often asymptomatic. Second degree may be symptomatic. Third degree practically always symptomatic and heart rate if less than 40, very high risk of syncope. On ECG, yesterday we discussed a little with you students ECG in patients with atrioventricular block, and I repeat a little for some students. First degree, only prolonged PQ interval, and patient may be without bradycardia. Morbus, second degree AV block, morbus type 1 and morbus type 2. This patient maybe with bradycardia because sometimes drop beats present in this patient and some episodes of bradycardia may be in this patient. And third degree AV block, no connection with atria and ventricle in this patient, and ventricle heart rate sometimes very, very slow in this patient. And of course, very severe bradycardia and syncope may be in patient with third degree AV block. Management of bradycardia pulses connected with chronic atrioventricular block, practically the same with patient with SA node disease, pacing, temporary or permanent, acute treatment, and let's discuss recommendation for pacemaker implantation. Class 1, obligatory, we need to implantate for this patient permanent pacing. If your patient with third degree or high-grade EV block at any anatomic level with symptomatic bradycardia, essential drug therapy that produce symptomatic bradycardia, if periods of asystole more than 3 seconds or ventricular rate less than 40 beats per minute for this patient, of course, permanent pacemaker. Catheter ablation of the AV junctional. Second degree AV block with symptomatic bradycardia, type 2 second degree AV block with white KS complex, with or without symptom. And if your patient with neuromuscular diseases that associated with conduction disorders, for this patient also we recommend permanent pacing. You see class 3 asymptomatic first degree AV block, this patient needed permanent pacemaker. And some patient maybe with acute MI and with atrioventricular node problem, and some patient also with MI need permanent pacing. Second degree AV block with MI, we recommend transit advanced infranodal AV block and associated with fundal branch block. For this patient, also we recommend permanent pacing. And that's all, students. That's a very short lecture in bradycardia. And if you have any question about arrhythmias, I have time to answer your question. If no question, if no question, we finished our lectures and have a nice day. Tomorrow will be to lecture on the polyclinic. We start at 10:15, I think, and will be two lecture. First lecture about MI, myocardial infarction in polyclinic, and second my lecture, heart failure in polyclinic tomorrow. If no questions, students, I say you goodbye. Have a nice day.